I'm Marco Vecchiato, and I'm a sports and exercise physician, and I work in Padova University Hospital, and I'm part of the Italian initiative Exercises Medicine Italy. During recent years, there has been a real growth in mountain tourism, but this has also generated an increase in rescue calls, with the Italian record of more than 10,000 rescue calls during 2021, despite pandemic restrictions. This can be substantially attributed to the new trend of tourists approaching to the mountains without an adequate physical or technical capacity. The mountain environment has specific altitude-related characteristics, such as hypobaric hypoxia and decrease in temperature, which are additive in causing stress and discomfort. The altitudes of clinical interest, which are usually reached by tourists during leisure activities, are those between 1,500 and 3,500 meters. Let's see how our organism adapts to high altitude. Hypoxia induces several different molecular and physiological adjustments that are useful to maintain adequate oxygen delivery to organs and tissues. Hypoxia, inducible factor, is the master regulator of the response to hypoxia. It is expressed in different tissues and it regulates different activities, such as erythropoiesis, angiogenesis, and apoptosis. During acute exposure to high altitude, there is an increase in ventilation, resulting in respiratory alkalosis. After a few hours, kidneys increase bicarbonate extraction and urinary output to compensate respiratory alkalosis. Moreover, it is possible to observe also an increase in sympathetic activity, cardiac output through an increase in heart rate, and also in blood pressure at rest and during submaximal exercise. Another crucial role in the physiological response to hypoxia is played by the oxygen-hemoglobin dissociation curve. In a normal subject, the sigmoidal shape of the curve allows saturation to be maintained up to 2,500 meters, while at higher altitude, small decrease in partial pressure of oxygen cause large oxygen saturation changes. If acclimatization does not take place properly, it is possible to develop high-altitude illnesses, and in some, thankfully rare cases, even a medical emergency. It is also necessary to consider that altitude has a negative effect on maximal aerobic capacity. Therefore, in order to maintain the same level of physical intensity, the exercise loads must be reduced. Moreover, the most popular outdoor mountain activities is hiking, and this often implies carrying a backpack, which can have a significant impact on the energy expenditure of the planned activity. So, why should we recommend to our patients to go to the mountains? Since we all know that it is difficult to engage people in regular exercise, physical activity in mountain environment can represent an additional experience in nature or a chance for socializing. Individuals may therefore be more willing to spend their time in this type of training sessions. Moreover, spending time in contact with nature has numerous demonstrated beneficial effects related to air quality, inhalation of volatile organic compounds with anti-inflammatory effects, and production of vitamin D and nitric oxide, which play a key role in immunoregulation. But what could we say to people affected by chronic disease? Are there greater risks for them in mountain environment? I will try to briefly explain the main lung, cardiovascular and metabolic disorders that can be affected by high-altitude exposure. Let's start with the lung diseases, and especially COPD, a condition strictly related to hypoxia. When exposed to high altitude, patients with moderate or severe COPD reduce exercise capacity and show arterial hypoxemia and tissue deoxygenation. The physiological problems that they present at sea level, especially pulmonary hypertension, can only increase when they are exposed at high altitude. For this reason, all patients with COPD should receive a medical assessment before a mountain hike. Most of these patients think that mountains should be completely avoided, but this is not true, as moderate physical activity is generally well tolerated. The most important thing is to monitor oxygen saturation, and if this lowers or the pre-evaluation tests were positive, an oxygen supplementation should be always recommended. If for patients with COPD, the risks of high altitude exposure are probably higher than the benefits, the same cannot be said for asthma. It is known that high altitude exposure increases the risk of asthma exacerbations, as certain environmental factors induce bronchospasm and increase bronchial reactivity. On the other hand, several benefits are evident for different asthma phenotype, in particular for allergic asthma. Lower allergen exposure appears to reduce histamine release and IgE antibodies, decreasing airway inflammation. Thus, a patient with well-controlled asthma should not necessarily receive a pre-travel evaluation. But if the asthma is not or poorly controlled, this patient should avoid high-altitude exposition. Moving to cardiovascular disease, low oxygen availability can exacerbate symptoms in patients with heart failure or coronary artery disease, such as dyspnea or angina. If a patient has difficulty in daily living activities at sea level, that patient will have even more problems at high altitude. Since it is known that altitude can influence the ischemic threshold, patients with CAD should receive a maximal pre-travel exercise testing, and exercise prescription should be adapted to new heart rate thresholds. As you can see in this table summarizing the latest European clinical recommendation, only unstable or class 4 patients should avoid high altitude exposition, while moderate or low risk patients should reach high or very high altitude with light or moderate physical activity, respectively. Finally, the role of the exercise in controlling cardiovascular risk factors in patients with metabolic disorders is well known and studied, and this is particularly true in mountain environment. However, for patients with diabetes, altitude can have a hardly predictable effect on glycemic control, particularly for insulin-dependent patients. As a general rule, it is possible to state that in the absence of macrovascular complications, a patient with good control type 1 or type 2 diabetes can also reach high altitude. It is essential to frequently monitor glycemia with a minimum of 6 times per day, and short-acting insulin should be always available. Repetitive uphill and downhill trails can cause ankle, hip, or knee pain and aggravate osteoarthritis and loading arthropathies. Some possible advice may be to avoid high slopes, slow down your speed when descending, and to use trekking poles. As we have seen, the benefits of exercise in the mountains are manifold, but particular attention must be paid to the special conditions of the environment. As the average age of hikers is rising, a lot of them suffer from chronic disease. Wouldn't it be great to have a tool able to provide personalized information to increase their safety?